So I will take a slightly different tact here, focus a bit on history, what we used to believe, what we believe now. Might be a little more qualitative because I'm not going to show you techniques, just thinking. So in 1993, I started this journey when I came on my traveling fellowship, and there's been much wisdom in Europe. The problem is, as Christian Gerber would say, that I'm 100% certain that 50% of what I know is wrong. And so these were the menu for the kinds of things we would do with these sorts of problems. And then in 2019, I was in Paris, and again, things hadn't changed very much. And then now I've been asked to come back and at this meeting to talk about mid-size and massive rotator cuff tears and indications for repair. Not how repair, but indications for repair. So I have some conflicts. I will talk about no products here, so that is not so relevant. For those who wonder, my journey has been starting in Europe, and then I ultimately wound up here at the Mass General Hospital. And along the way, these things have been part of my life. And now Bassem has moved into my office and has taken over my practice, and I live a much nicer life in the country near my home, working in our outpatient center, which I'll talk to a little bit about in terms of the value of rotator cuff surgery and cost and efficiency of care. Those who are interested, see me. I'm happy to have you be part of Codman Shoulder Society, which looks at value. It looks at the implications of what we do throughout the episode of care, rotator cuff and other things. And we have a lot of things posted on these kinds of thoughts. And so I think the first time I came here was the 2019 course. And what I've learned is that over the years, experts will change and leave, and they will be replaced by more experts, and even more experts, and even more experts in different courses. And frankly, it was Franklin D. Roosevelt who said there are as many opinions as there are experts, and Christian Gerber said if two people agree, one is not a surgeon. And nothing has changed. Well, if we talk about eminence, I'm an expert, versus evidence, then it starts really with Neer, because when Neer talked about acromioplasty and chronic impingement being the extrinsic cause of rotator cuff disease, he was fundamentally wrong. And this led to a feud between him and people like Gerber and others that pointed at. And if we look at articles on this, almost 3 million articles on the difference between being an expert and using evidence. And of course, Mo Bandari wrote a book about this. So if I will show you evidence here, you should be confident to know that there will be an article that's exactly the opposite in conclusion. So this article that I participated in, which was a comparative analysis, and you already saw one of these, operative versus non-operative treatment, clearly showed that randomized controlled study of operative versus non-operative treatment for rotator cuff surgery wins. Now, you saw more nuances here in the recent talks, which really take some time to identify that we have a heterogeneous population. And Carl, in the work that he did, clearly demonstrated the motivation here that after successful arthroscopic repair, rotator cuff tendon tear induced fatty infiltration can almost be stopped, and muscle atrophy can even be slightly reversed. So you better operate on these people before they become problematic. And of course, Jay talked about this a little bit. Well, we have so many promising technologies, particularly when we're at that position where we have to decide what will we do for these patients. These are not for rotator cuff, but this idea of Scott's parabola of enthusiasm and then evidence and loss of enthusiasm affects much of what we do and what we see. So these are technologies I will not talk about, but that are there. They include double row repair that we've talked about, transosseous equivalent, in-space balloon, patch augmentation. These will be parts of our conversation in the meeting. But what is more important is us. So when a patient comes with a rotator cuff tear, these are the pathways that patient may follow that determine the value of the care they receive. So if they go see the orthopedic surgeon, does the non-orthopedic surgeon send them for all these other things first, PT, injections, etc.? And ultimately, when they see the orthopedic surgeon, is this a shoulder surgeon, a sports surgeon, a hand surgeon? Because all of the pathway that they follow depends on the biases we each have for what we believe in the literature and what we believe in our own opinion. And this is why we have such a mess, at least, can we go back here? Such a mess in what we do. So it was Voltaire who said, if you want to discuss, we need to agree on words. We don't even agree on this. So let's look a little what is published. If you look in PubMed on rotator cuff repair, I mean, that's not quite 8,000 articles, but look at the growth of these articles over time. And it is the same for massive rotator cuff tear, growth of these articles, and also the same for irreparable rotator cuff tear. Even though we don't agree, we have a huge volume of information. And even if we look at ViewMedi, which is the largest repository of articles of videos, and then we looked at the Balgrist University contribution, you can see all the videos here. These are barometers of what we together seem to believe and what is popularized. Now I will come back to the ultimate cynic, Christian Gerber, who showed this graph at the Codman Shoulder Society annual meeting in 2023. I recommend you should watch his talk on innovation. And if you look at the number of published articles, as you see here in the line that goes very vertical, and then you look at the postoperative scores and improvement after surgery, there is zero effect. At least he says zero effect on the outcome of patients. So what are we doing in terms of return on investment of all the research that we are doing and the presentations we are making? It would appear to him nothing. Well, Einstein said everything should be made as simple as possible, but not simpler. So we have to ask questions first. So what does this diagnosis mean to you? Are you treating pain? Are you treating weakness? Are you treating muscle atrophy? If this patient and this patient walk in your office, they have the same size tear, what will be the treatment for each? Well, of course, it's individualized according to the needs of the patient, but with the context of what Jay just showed you, what is the future, which they will ask you. Now, if you look at this patient, that's completely different. And of course, this is a family of conditions that we call large rotator cuff tears, massive cuff tears. So what do I know? Massive is not irreparable. Pathology matters. We've seen this already. The history matters, the symptoms, comorbidities, and the clinical presentation matters relative to weakness versus pseudo paralysis and things of that nature. And so when we went back in the beginning and we were measuring simply size, as you see here Cofield did, and it was done open, that was quite a different approach and different understanding. And you can look at all these different classifications and how we might proceed. And if you look here at this work of Bob Cofield on how to treat these tears, only 10% were massive. So how do you come with a conclusion what you should do when such a small percent of your population are these tears? And Christian Gerber pointed out some time ago that there is no universal agreement on the definition of a massive tear. And frankly, he felt it involved 2 tendons minimum after you debrided what was not worth repairing, which was different than most. At your EFORT meeting in 2015, it was Colin that asked the question, when and how do you define what you will do? And of the 15 surgeons he spoke to, 11 made a decision before the surgery based on things we were talking about here, but they were different emphasis that these 11 had. And 4 said, I just operate and then decide when I'm there what I can do. Now, I know that some operations fail before you start, and we would all agree that that is not a case for a repair, and that is not a case for direct repair, and that neither as well, but it's taken some time for us to understand all the mistakes that we made in our assessments. And today, you've already seen this, these are factors that are relevant to decisions we make. So context matters. The shoulder belongs to a person, and each person is different. And so we have to then decide what we do with those people. And this is similar to what you've already seen, that age is important, certainly an important factor for healing, for re-tear rate. We all understand this now, and we all know the work of Goutaillier on fatty muscle degeneration. I just show this for context because everybody knows this classification. But you know, it was here, I think, that one of the best articles ever written that looked at actually the impact of what happens with the muscle and the tendon was this one by Dominic Meyer and Christian Gerber in the American Journal of Sports Medicine that pointed out the importance of the length of the tendon and also the fatty atrophy. And together, a more powerful predictor of repairability than Goutaillier grade alone. And in fact, if you look at the tendon less than 15 millimeters, the odds ratio for re-tear rate was very, very high. And this was a very sensitive and specific study. So failure rate here, depending on the size of the remaining tendon that was left to fix, and the fatty atrophy is important. And he said in 2006, I left off one thing here, but he said there is little likelihood that a contracted, fatty, infiltrated, atrophied muscle will ever likely function again. You know, fat does not contract, just look at me. That's his humor. I will say that we were talking about progressive fatty atrophy. in the Journal of Orthopedic Research, he published a long time ago on lipid content that you don't see with your eye. And the lipid content goes up progressively from partial to full thickness tear. And so the structural characteristics of the muscle tendon unit change before you can see with your naked eye what is actually happening in the patient. Well, mistakes I've made in 1998, this was my first patient who was a rugby player, young guy, was a resident, 30 years old, and he had this appearance of his subscapularis. And I defined that this was truly irreparable because the tendon was on the table when I tried to mobilize it. And you can see here, I should have known better with the exam, but we know better now. And we also know Hamada classification, which helps us. But we still argue about stiffness versus weakness and assessment and active and passive motion. And the Hornblower sign we all know now in terms of posterior rotator cuff. But do we also look at the patient? And when you look at somebody like this where the teeth to tattoo ratio is less than 1, and depression and narcotics and history of smoking and work-related injury, there is almost nothing that will make me operate on that patient. It's like, now, in this 39-year-old man, after a fall with complete pseudo-paralysis and cannot raise his arm, can we reverse this? The answer is absolutely in these circumstances. So when you look with this healthy muscle, and at this patient here who has an immediate repair, that is kind of an emergency that you should fix. If you leave that, that's a different problem. Or this patient here with a chronic rotator cuff tear who functions very well. We've already talked about that. We know how we will treat her. And we have many articles. Here's the Moon Group. This is an article from Finland, prospective randomized study demonstrating that at 1 year, whether you operate or don't operate or do a debridement, exactly the same outcome. And this one here from the Moon Group, which has already been referenced, that shows that non-operative treatment is very successful. This is a young Basem, in case people are wondering, in 2006, looking at one of my patients with a arthroscopic debridement of a tendon tear that looked like that. And how will he do? Well, Rockwood told us they will do great. 83% satisfaction. And it was Charlie Neer at the 1988 international meeting that walked up to the microphone after Rockwood presented this and said, the diagnosis of an irreparable tear says more about the surgeon's skill than the patient's tissue. And of course, if you look at these outcomes here with biceps tenotomy, like Walsh had popularized, and Apoil and others, there was a very high failure rate over time after debridement with tenotomy. And Buddy Sawal won the Neer Award for this study that demonstrated only 8% satisfactory after 6 years. So partial repair, Steve Burkhardt has told us this. The peculiar thing is that his outcome with partial repair versus full repair versus SCR are exactly the same statistics. So I get a little confused between one versus the other. Now, I finish up a little with pseudoparalysis. When you look at this patient here on the left, and you look at this patient at the same time on the right, which is pseudoparesis and which is pseudoparalysis, and which one will benefit from tendon transfer, which one needs a reverse? So we make these decisions. We will cross over into reverse, I think, tomorrow. But I finish up with this very nice article already demonstrated. And this is a very important article, because when I look at the configuration of tendon tear, inclusive of the other factors, then I know that that patient there, and that patient there, and that patient there are likely to be the ones that I can do a repair for, and the others something else. So I would say, what have you learned after this session? It's still the same, that we all maybe have different biases and don't agree on everything, but it's through critical introspection with what you actually do and how it works that you curate from all the noise what is the right thing to do for each patient. Thank you.